Next, I call upon Dr. Benjamin, who is an accomplished and dynamic pulmonologist from the Department of Pulmonology, CMC Vellore. He has a keen area of interest in sleep medicine and interventional pulmonology and is here today to discuss about sleep disorders in chronic kidney disease. Thank you, sir, for being with us. I hand over the stage to you.
Thank you, one and all. So, regards from the Department of Pulmonary Medicine, CMC. So, I am here to discuss with you about the sleep disorders and CKD. You might be wondering why we have to bring in this topic about sleep when you have been discussing about, serious topics like kidney disease and all those. So, as we go through the presentation, we might be like mutually understanding what are the key concepts which made the, organizers think about sleep. And so as you know that the World Health Organization says the health means a state of complete physical, mental, and social well-being and not merely the absence of disease or infirmity. Also like nutrition and physical activity, sleep is also an essential pillar of health. Sleep, it can be a neurobehavioral complex. It's a state which involves widespread changes in the brain and systemic physiology. So sleep is also a pillar of health, is what I want to say. And there are multidimensional aspects in sleep. If you think about a quality sleep or efficient sleep, what you'll be like thinking about? If you are saying that I have slept well, my sleep was good last night, what do you mean about that? Is it the duration? Is it the quality? Is it the efficiency of sleep? Yeah, so sleep is not just one entity, it's a multi-dimensional entity. And as it is mentioned here, it involves duration, it involves efficiency, it involves alertness and sleepiness. The time you have to sleep, you have to sleep. The time you have to be alert, you have to be alert. It can't be the other way, right? So also the timing you sleep and the satisfaction you get while sleeping, after sleeping. And so there is no single metric. Single metric is not sufficient to fully capture the quality of sleep and its effect on health. Okay, so these are some of the data got by the World Sleep Society in 2023. So they were just checking whether they have adequate data to compile it. So they were checking about the sleep duration, because that is the commonest thing which we can get from the community about how well they slept. Right, so as you see here, like the blue ones, the blue countries which is mentioned here are the countries which have, from the general population data. And the countries which has been mentioned here in green are the specific population data, like say, for example, drivers or, some specific workers. And the red ones are the ones which doesn't have data at all. So if you are seeing both the green and the red ones, almost like 78% of the world countries doesn't have data about sleep duration. So this gives us a wake-up call. The paucity of this global data about the sleep duration itself serves as a wake-up call to us. And it means that there is no national health agenda or a sleep health agenda in those countries. Okay, so when we sleep, what all stages we go into? So you might be aware about this. When we are, after being awake, you enter into the stages of sleep. You enter into stage 1, NREM, which is divided into NREM stage 1, 2, 3, and then REM sleep. This happens in cycles, as this hypnogram points out. So this kind of image you will be seeing in a polysomnography. So when we sleep, we enter into the different phases in almost like 4 to 5 cycles. Right, you can see this red being the REM phase. You are getting it in the second half of, more clubbed in the second half of the sleep. So if you say you had got a very good adequate sleep, this hypnogram should be smooth and you should have entered into all the sleep stages, and it should be consolidated, and there shouldn't be any wake up after sleep onset. In the sense, there shouldn't be any disturbed sleep in between. Okay, so now about the prevalence of sleep disorders. So the reported prevalence of sleep disorders in patients with CKD ranges from about 50 to 75%. It's a very huge number. 50 to 75% of patients, CKD patients, have sleep disorders. And you might be wondering what sleep disorders are. So in our practice, we might be like seeing more of obstructive sleep apnea, isn't it? So, but if you see, the sleep disorders is an umbrella term which comprises of multiple other things like insomnia. It has sleep-related movement disorders like restless leg syndrome, We have central disorders of hypersomnolence, means excessive sleepiness that can be because of narcolepsy or other hypersomnias, and circadian rhythm disorders, and also parasomnias, which are divided into again NREM parasomnia and REM parasomnias. So there was a survey which was done in Italy, 883 dialysis patients, and they have seen that most of the dialysis patients were suffering from insomnia, followed by sleep apnea syndromes, and the rest as below. Okay, let me start with a case. Okay, you would have come across this multiple times in your clinics, right? So like one among that is like a 51-year-old male, a non-smoker with BMI of 25.2 and neck circumference of 37, with history of hypertension and chronic glomerulonephritis. And he was on PD for peritoneal dialysis for 3 years. And then he was treated with 2 liters exchange per day using standard islays that contain glucose. His urine volume was 0.8 liters per day. And then the residual renal function was 2.98 ml per minute per 1.7 centimeter square. So the lab parameters are that, HB of 11.2, creat of 14.3 milligram per deciliter. And he gives some sleep complaints, right? So he says he's having excessive snoring. He says he's having excessive daytime sleepiness. He doesn't have any, there are no witnessed apneas, and there is excessive fatigue and fragmented and non-refreshing sleep, and no other abnormal sleep behaviors. The stop bank score being 4, the ESS score, I'll come later what are those scores mean, ESS scale of 15. So what do you think in this? I mean, with this history, with the background history of a CKD patient comes here with this sleep complaints, you would have come across multiple times, I mean, patients like this multiple times in your clinics, isn't it? So what comes into your mind when you look at this history? Sorry? OSA, right, so good, OSA. Any other differentials that you can put in from the previous slide that I had put, means the multiple sleep disorders? Sorry, sir? Inadequate dialysis, okay. Pertaining to sleep, sorry. Okay, so OSA is the right one. And then fragmented and non-refreshing sleep, I might be thinking might be having some kind of insomnia as such, but we don't know the other characteristics of insomnia. Yeah, so the stop bank score, I'll come later, but most of you are aware about the stop bank score, am I right? Okay, and then Epworth sleepiness scale, that is the capacity, the measure of how wakeful the patient is or how sleepy the patient is. So 15 is high, means it should be more than 11 to call that patient is excessively sleepy during the day. Stop bank score of more than 3 also, it's a pretest probability of obstructive sleep apnea is more than 3. So patient was diagnosed to have obstructive sleep apnea and he was put on the PAP trial and he was put on CPAP. So you can see that this is the polyglossomnography variables which was caught in the patient. So you can see the AHI was 50.7, which is more than 30, means there is some classification for the AHI, I'll come to it later, and most of it were obstructive apneas. So he was diagnosed to have obstructive sleep apnea, as you said, and then patient was put on CPAP, and you can see the lowest saturation was 78% when he slept. And with CPAP, is all the parameters improved, means his cognitive function, sleep, his mood, quality of life had improved compared to previous from baseline to 12 months. So this is just a gist of like so many patients whom we see how we manage a OSA, but let me go deep into the causes of OSA. Okay, so the sleep-related breathing disorder, as you see here in patients with OXA, the obstruction usually occurs in the retropalatal or the retroglossal levels, and it causes collapse of the upper airway, and it reduces the intraluminal diameter and increases the airway resistance. So when that happens, there will be apneas and hypopneas. So those are terms which you have to understand. I'll go through it later. So apneas and hypopneas, that characterizes the OSA. As I said, the upper airway tone is decreased during sleep, and especially during the REM phase, and the collapse and obstruction of the upper airway during the sleep causes obstruction and apneas. So what happens during sleep? So what happens is when the sleep onset happens, so there will be loss of neuromuscular compensation and decreased pharyngeal muscle activity, so leading to airway compromise, causing apneas, and then hypoxia and hypercapnia, and which increases the ventilatory effort. You know, like carbon dioxide being the main trigger for the central chemoreceptors. So when that happens, there will be increased respiratory effort, which can arouse the patient from sleep, and again the pharyngeal muscle activity will be restored when he is awake, and again the airway will open, And when the airway opens, he might be hyperventilating to correct his hypoxia and hypercapnia. And then again, he might be going to sleep, and this cycle continues. So when such a thing happens, so that is what OSA is characteristic of. OSA is defined by apneas and hypopneas associated with repetitive episodes of intermittent hypoxemia, during which the intrathoracic pressure changes and arousals also happen. So this intermittent hypoxemia is now being recognized as a potential major factor contributing to the pathogenesis of OSA-related comorbidities. Okay, so the global prevalence of OSA is around 0.3 to 5.1 in general population, and in India, it varies from 4.4 to 13.7. So this is what happens when we suspect OSA, right? Even in your clinics, you can see patients with probable OSA, you send to the respiratory physician, and then they undergo a sleep test. So there are multiple levels of sleep tests. So this is how a standard of care sleep test is done. It's called as a polysomnography, where they will be hooked on with multiple leads. So one among them is the EEG leads, one for the airflow sensor, another, the one for the ECG, one for the chest bells and the abdominal bells, which measure the respiratory movements. Okay, and the the limb leads will measure the limb activities during night. So there will be a pulse oximeter. So that is how the apneas are also captured. Apneas means there will be a drop in peak thermal sensor exertion by more than 90% of the baseline. The one which is connected to the nose, it will not measure the airflow. If it doesn't measure, if it has to be more than 90% of baseline and lasting for at least 10 seconds. Hypopnea is almost similar, but drop is just by 30% from baseline, lasting for 10 seconds, associated with 4% or more desaturation, or it can be associated with an arousal. So that is what hypopnea means. Okay, so this apneas and hypopneas put together, there is a score which is called as apnea-hypopnea index, which is an average with total of apneas, hypopneas divided by the total hours of sleep duration. Okay, so this is how we differentiate central, obstructive, mixed, and hypopneas. So central apnea, you can see there is no neural output, means from the central there is no command to breathe. So that is the nasal airflow doesn't record the breath, and the abdominal and thoracic movements also doesn't move. So completely out, so central apnea. Obstructive apnea, there will be no nasal airflow because the obstruction is at the posterior pharyngeal or the retropalatal, but the abdominal movements and the thoracic movements will be there, just that flow cannot be detected. So that is obstructive. Mixed can be a mixture of both central and obstructive. And hypopnea, as I said, it is just 30% reduction in the airflow. So that is what is caught. It is not a flat line, unlike your complete apnea. It is just a partial reduction in the airflow. Okay, so this is the severity. OSA is classified as mild, moderate, severe, 5 to 15 mild, 15 to 30 moderate, and more than 30 severe. So now, despite the high, you can see compared from general population, where does CKD and end-stage renal disease stands? Means the prevalence of the sleep apnea, it is more in CKD and end-stage renal disease compared to general population. But despite the high prevalence of sleep apnea in CKD and end-stage renal disease, the presence of sleep apnea in these patients often goes unnoticed or unrecognized. Why do you think so? Why do you think so? Because in our OPD also, like the patients whom we receive for sleep apnea evaluation or screening, we don't find much CKD patients. Okay, so one reason being lower BMI. Okay, so these patients doesn't have to have a higher BMI to label them as OSA. You can see one study where they have compared in the end-stage renal disease group, compared to the normal group, the mean the BMI was much lower compared to the ones with the actual OSA. Also, the symptoms are not so evident. So you can see patients will not have the typical symptoms of snoring or witnessed apneas or even the morning headaches. So sometimes the daytime fatigue, the daytime somnolence, or the daytime sleepiness, even the CKD patients have. So there is no specific symptoms in CKD patients to directly screen them or directly label them as OSA. That is why the scorings like stop bank score or ESS scores are all obsolete in this set of patients, CKD and end-stage renal disease patients. So even some studies have proven that all the screening instruments are just satisfactory, having satisfactory sensitivity, or they have a poor specificity and low accuracy in both CKD and end-stage renal disease patients when they are having OSA. So what I am trying to tell here is our threshold for suspecting OSA in CKD and end-stage disease patients should be so high, means like even if the patient has mildest of symptoms, even if they're saying just snoring, or if they're saying just they have excessive daytime sleepiness or disturbed sleep, anything has to be considered serious and the patient has to be referred for further evaluation. So there is a bidirectional relationship between CKD and OSA. There has been a recent meta-analysis conducted in reported in 2024, which says that the risk of CKD in the presence of OSA is so significant. It's higher in OSA cohort. It holds true for the other way around. Even the risk of OSA in the presence of incident CKD is also high, as per this meta-analysis. Okay, now what is the pathophysiology which lies behind? Despite receiving approximately 1/4 of the resting cardiac output, renal oxygen tension is relatively low. It's because the renal oxygen consumption is low in the kidneys. The kidney medulla, which is particularly sensitive for hypoxia, what it does is because of the chronic hypoxia, there will be multiple things which are happening. One such thing is you can see here from obstructive sleep apnea to CKD. Patients with obstructive sleep apnea will have multiple things like oxidative stress, hypoxemia. Also, they will have hypertension because of the renin-angiotensin aldosterone activation. So all these things can cause tubulointerstitial injury, and then which can cause functional damage, and then chronic kidney disease. On the other way, chronic kidney disease also can lead to OSA. You can see that chronic kidney disease will cause metabolic acidosis, and metabolic acidosis will end up in hyperventilation, hypocapnia, and then enhancement of chemoreceptor reflex, and then the destabilization of the respiratory control system happens, alteration in reflex control, reduction in PCO2 because patient is hyperventilating, so reduction in PCO2 below the apneic threshold, and then patient will go into apneas that can cause obstructive sleep apnea or a central sleep apnea. And in case of end-stage renal disease where there is sodium and water retention, fluid overload, what it does is it will cause pharyngeal narrowing and tongue enlargement because of the rostral fluid shift, and then patient will have airway obstruction during night causing obstructive sleep apnea. So there is a bidirectional relationship always between CKD and obstructive sleep apnea. So there are some studies which have proven that. So compared with control patients without hypoxia, patients with hypoxia had an increased risk of rapid loss of kidney function. Also, you can see that stage 3 to 4 CKD, the decline in GFR over 1 year was greater in patients with the AHA or the DA more than 15 per hour than compared to those who DA is less than 15. So the worsening kidney function is determined by the control of OSA and vice versa. So how do we manage the obstructive sleep apnea? So when you suspect, we refer to the sleep physician, and then we do a diagnostic sleep study, and then if needed, we do a CPAP recommendation, CPAP titration study, and then if CPAP fails, then again sleep physician has to evaluate, and then if needed, oral appliances or other conservative measures has to be tried, and this has to be done, reassured, done in cycles, and we have to follow up the patients. So what does CPAP does? The PAP therapy in general, PAP, CPAP, or a BiPAP, what it does is it prevents the downstream effect of OSA that are potentially deleterious to kidney function. It leads to augmented renal plasma flow. It slows the kidney damage. It shows significant beneficial effect on BP control and sympathetic nervous system activation. There are other few therapies, which like a positional therapy. You can see that patients are advised to sleep in one position rather than being in supine. You can see these are some of the measures that we advise. Keep some tennis balls in the some kind of cloth and then tie it in the waist and tell the patient to sleep in the lateral side. And these are some of the ready-made things, ready-made gowns which are available. And there are some bells which gives kind of electric kind of sensation when the patient turns to the supine position. So even positional therapy has been, it had shown that positional OSA is around 67% in Asian group, and almost like of these patients, the AHA normalized when they were not in supine position. Okay, let me go through the sleep study report, which you can quite often encounter in your clinic, right? So you would have seen somewhere in your clinic, sometime in your clinic, you would have gone through the sleep study report, am I right? So when you see the sleep study report, there are a few things which have to, which should not be missed. So say a patient comes to you, he comes with the sleep study report. So what all things we have to see is, you can see there are a lot of obstructive events, the number and the index. There are no mixed, no central, and you can see the, hypopneas are around 149. So on an average, hypopnea, apnea, For the duration of sleep, it was around 58, that is the AHI index, so that is around 58.8, and it is under the severe OSA group. And these are in the positions, how the saturation was, or how the events were with different positions. You can see that most of the time patients slept in supine position, and then during those times the obstructive events were more, even the hypopneas were more, and the number of desaturations were more in the supine position compared to the rest of the position. So it can be labeled as a supine OSA, supine phenotype, and what we can advise is a positional therapy in these patients. And you can see this oxygen saturation panel. You can see the minimal saturation was 79, and this parameter, the saturation time less than 90%, it says patient spent less than 90%, almost 11 minutes, 10 to 11 minutes. So that is a very significant quantum of number, because patients spent less than 90% during a significant amount of time during his sleep. So we can tolerate until 90%, less than that, it has to be considered significant. So this patient was diagnosed to have severe sleep apnea with significant desaturation. Okay, and then the next thing we did was doing a PAP trial on him. So this PAP trial with auto CPAP, auto set mode, done, showed with 95th percentile of the pressures, around 11 centimeter of water pressures, the AHI, which initially came as 55 or whatever, it had completely eliminated to 0.6, which means the AHI was completely removed off, abolished with the use of CPAP. And the saturation, minimum saturation was just maintaining at 90, and never it was less than 90. So this is the graph which you can see, or the diagram which you can see in the sleep study report. You can see from around 12 to 4 a.m., so you can see that there are a cluster of events happening. Those are the snore events and flow events, the saturation events, and the SpO2 drop. So it is more in the mid of the night, and you can see that most of it were in the supine position. And this is a polysomnography image, which says that during the REM phase, there were a lot of respiratory events, and then there were significant desaturations happening during the REM phase. So this is a REM phenotype of OSA. Okay, so that is how we diagnose OSA, and then we treat OSA, even in CKD and in a non-CKD patients. The second big thing is insomnia. Okay, what is insomnia? First of all, the prevalence of insomnia. Almost 48% of patients with CKD not receiving kidney replacement therapy experience insomnia. And this is one questionnaire to know what is the insomnia severity of the patient. So what is insomnia? Insomnia means it is trouble falling asleep, trouble staying asleep, and trouble falling back to sleep. Okay, this is the three main components. Even when you're encountering a patient, if he says he is having sleep trouble, just these three questions, I think will give you the answer, right? Trouble falling, trouble staying, and trouble falling back to sleep. Okay, what are the things which contribute to insomnia in a CKD patient? You can see multiple things mentioned here. One is they can have associated restless leg syndrome. They can have multiple metabolic factors which can impact the sleep quality. They can have added circadian rhythm disorders which can affect the sleep quality. Elevated plasma orexin level. Orexin is a neuropeptide promoting wakefulness. It will keep the patient awake. And melatonin disruption. CKD patients have melatonin disruption. So melatonin is the important thing for the patient to have a proper circadian rhythm. If it is not there, then patient will be awake. And sleep apnea can be associated with that. Anxiety and depression, and medications and poor sleep hygiene, systemic inflammation, and timing of the dialysis shift. So some studies suggest that insomnia will be worse among patients dialyzed in the morning, so they advise to do the dialysis in the night. Again, this meta-analysis shows that there is a bidirectional relationship between insomnia and CKD. You can see that the risk of CKD in the presence of insomnia is significant, and then the risk of insomnia in the presence of CKD is also significant. Okay, how do you manage, evaluate? So when patient is having symptoms for more than 3 months, more than 3 times per week, nighttime and daytime symptoms, and then other comorbidities, we label them as chronic insomnia, and then we treat for the comorbidities and also insomnia. The primary treatment is cognitive behavioral therapy, most often done by the psychologist or the psychiatrist. So cognitive behavioral therapy, where there will be like in individual groups or self-help groups, and they will be like taught sleep hygiene practices and about this cognitive behavioral therapy. And if that fails, then we'll have to do psychoeducation and then consider drugs like Z drugs like zolpidem, zolpiclone, and benzodiazepine, short-acting benzodiazepines or sedative antidepressants. Also, melatonin can be given in those patients. So how do we evaluate insomnia? Insomnia we evaluate primarily by sleep diary, right? So rather than jumping into treatment, rather than jumping into any modern, investigations, a simple sleep diary means how the patient sleeps will give you a lot of clue. For example, this patient sleeps at around 10 o'clock in the night on most of the days in a week, and then he still stays in the bed. I mean, he has not fallen asleep. This shadowed area or the sleep areas where the time when he slept. So this shadowed areas were broken in between, means he is awake in between and then tries to go back to sleep, sleeps for 1 hour and then wakes up again. So on an average, his total spent time in bed is around 8 hours, but the time he slept potentially is just 5 hours. So you can see the sleep efficiency. Sleep efficiency means time in bed, time actually slept by time in bed times 100. So he wouldn't have slept efficiently. At least sleep efficiency should be at least 80% or more. He is spending more time in bed. So that is what the cognitive behavioral therapy does. When you are on bed, it is just for sleep, not for anything else. So whenever you are having sleep, that is the only time you have to be on the bed. So that is what cognitive behavior therapy does. And this is another modality by which we can capture that. Sleep diary is just objective, but this is subjective, this is an objective finding. So what this does is just like a watch which captures your movement. When you're awake, it will be like shown in black, and when you're sleeping, it will be shown in blue. And when you're awake, in between sleep, again it will be shown in black. So this is how actigraphy looks. So the patient here has slept adequately, from at least night 9 onwards till say 11, but it's still 11 in the morning. So this is how he has been sleeping all throughout the days, and also there will be like some daytime sleepiness also measured, and in between some activities also measured. So this will hold good for many of the sleep disorders, 1 insomnia, 2 circadian rhythm disorders, and so on. So what treatment we offer them is primarily, as I said, is a cognitive behavioral therapy. We'll have to make sure that the sleep hygiene is good. So they have to have an appropriate bedroom environment. They should avoid screen-based devices before bedtime, avoid coffee or alcohol consumption. Stimulus control is done by using bedroom only to sleep and then leaving bedroom when cannot fall asleep, right? So, and then sleep restricting the sleep times, and then increasing in-bed sleep times, and relaxation techniques, and then cognitive therapy like restructuring the undesired thinking patterns, and do this again and again by repeated sessions. So the next thing is restless leg syndrome. Okay, so restless leg syndrome is actually, a patient will have complaints of unpleasant sensation in the lower extremities, accompanied by uncontrollable urge to move the lower extremities. This occurs typically in the evening or early part of the night. It is worse during the day periods of inactivity, and it is relieved by movement. So that is what restless leg syndrome means. You can see again the prevalence of restless leg syndrome is more in case of CKD patients. In the meta-analysis of 51 studies, they estimated that 1/4 of the patients with CKD had RLS. And again, this meta-analysis had shown that there is a bidirectional relationship between RLS and CKD. You can see that it is significantly high in case of restless leg syndrome. And the other way, the restless leg syndrome is also significantly high in the CKD patients. Okay, why does this restless leg syndrome happen? So primarily because of the brain iron deficiency. So you'll know like how patients have anemia or iron deficiency in case of CKD and end-stage renal disease. So brain iron deficiency will cause decreased adenosine function, and then which will end up in decreased dopamine and increased glutaminergic activities. And then you can see that decreased dopamine will cause sensitive symptoms, and then PLMS, periodic limb movement disorder. So there will be a confusion always between restless leg syndrome and PLMS. So restless leg syndrome is a historical diagnosis. PLMS is a polysomnographic diagnosis. So, but the pathophysiology is one and the same. Okay, and because of the increased glutamate in the CNS, there will be sleep disturbances and hyperarousability. So the management also depends on this. So when we are managing a patient with RLS, you have to check for the iron deficiency and then manage by giving oral or iron supplements. And then to target this low adenosine, we have to give something called as dipyramidol. And then when we are targeting this glutamate, we'll have to give alpha-2 delta ligands like gabapentin and pregabalin, and then you have to give a dopamine agonist like pramipexole, ropinol, so which will take care of the symptoms of PLMS and restless leg syndrome. Okay, so some meta-analysis have shown that other therapies like cool diastylate and then intradialytic stretching exercises and pharmacological events like gabapentin are a useful treatment for restless leg syndrome in end-stage renal disease. Okay, the next thing is about the circadian rhythm disorders. So you can see here that the normal sleep phase, it has to be proper, at least 7 to 8 hours of sleep. Somebody should have slept from at least say 10 to morning 7 or 9 to morning 6. But if the phase is advanced, means the person is sleeping like earlier and then getting up earlier, it is advanced sleep phase disorder. If they are sleeping much later and waking up later, it is a delayed sleep phase disorder. And if the sleep cycle is broken in between, means like he's sleeping whenever he wants and then wakes up whenever he wants, like it's broken, like it's called as irregular sleep-wake rhythm. And non-24-hour sleep-wake rhythm will be like in the days of the week, on one day you'll be like sleeping earlier, one day later, much later on the other day. So these are called as the circadian rhythm phase shifts. This can be captured only if we know the sleep diary or only if we know the actigraphy. Okay, so as we know that the circadian rhythm plays a vital role in person's ability to sleep, and one thing is this melatonin, which plays a key role in the circadian rhythm. You can see that melatonin increases, the red one is the melatonin. You can see that increases when the night starts and then it decreases in the day. So in patients who have advanced sleep phase, what you have to do, give them is a light therapy. In patients who are having a delayed sleep phase, what you have to do is like bring them back to their normal sleep time by giving melatonin, and in the daytime to give light therapy. So that is why this melatonin light therapy are important. And you can see that in CKD patients, what is affected is in the night, the melatonin production is affected in the night. So you will understand how a circadian rhythm comes in a patient with CKD or end-stage renal disease. So melatonin production is decreased in the case of CKD patients. So what happens is melatonin amplitude and melatonin rhythm decreases with advancing renal dysfunction. The high level of tumor necrosis factor seen in patients with renal disease is probably involved in blockage of melatonin production, and circadian melatonin rhythm may be absent in ambulatory peritoneal dialysis and conventional daytime patients on hemodialysis. So you can see that this picture shows that in cases of CKD, melatonin is decreased, and so giving exogenous melatonin will decrease the rest of the complications like sodium retention, and then the inflammation will decrease, the fibrosis will decrease, the sleep will improve, blood pressure will improve, finally decreasing the severity of CKD. So how do we treat this circadian rhythm disorders? Like nocturnal dialysis is one option, and then lowering of diastolic temperature, administration of exogenous melatonin, administration of exogenous erythropoietin, bright light and intradialytic exercises. Okay. The final thing, though it appears insignificant, but one important sleep disorder are the parasomnias. Parasomnias are an abnormal sleep behavior during night. I don't know whether you would have encountered that, even a sleep physician, or we don't usually encounter parasomnias. Though they are rare, they have to be considered little serious. So you can categorize it as NREM parasomnias or REM parasomnias. The ones which happen during the NREM phase are those, and the ones which are happening during REM phase are the REM parasomnias. So those are classified as sleepwalking. The NREM are classified as sleepwalking, sleep talking, sleep terrors, confusional arousals. The REM ones are REM sleep behavior disorder, in which patients might be enacting their dreams itself. So usually during the REM phase, there should be complete atonia, means the muscles shouldn't be actually functional except for the diaphragm muscle, because patient has to breathe. But in case of this REM behavioral disorder, what the patient will do is he will enact dreams. So when the dream comes, he'll be enacting that. So that can be sometimes violent. And there can be nightmare disorders, there can be sleep paralysis, and then hypnopompic hallucinations. So what is the prevalence? One study had captured that in patients with end-stage renal disease on hemodialysis, 13% of patients had nightmares, 2% had sleepwalking, and 2% had possible REM sleep behavior disorder. While among CKD patients, the 15% of patients had nightmares, 4% had sleepwalking, and 3% had REM sleep behavior disorders. Just want to show this a video, a small video. This is a patient, or sorry, a person who is like getting a dream in the middle of the night, and he dreams as if he is a samurai warrior or someone, okay? You can see how he behaves during the sleep. This is during the REM phase. Mind you, he is still asleep. So he is taking off his sword, and he's literally stabbing someone, right? And then he goes back to sleep again. Okay, imagine if he really had a knife with him, or there was some sharp objects near the bed, and there was somebody who was like sleeping next to him. Just imagine the plight of the partner and the scenario how it would have been. So that is how the REM behavior sleep disorder can be dangerous. And as I said, the prevalence, though it is very less, but still it has to be considered serious. So the treatment options are environment precautions, clonazepam, melatonin, and other less frequent medications like non-clonazepam drugs, dopamine agonists, and carbamazepine. So the take-home points from my presentation would be sleep disorders are common, multifactorial, and often under-recognized in patients with renal diseases. Sleep disorders have a negative impact on well-being and quality of life. There are definitive association between kidney disease and various sleep disorders, and prompt referral to sleep medicine specialist for further evaluation is necessary. There is a need for the nephrologist and the sleep specialist to jointly recognize and tackle the sleep complaints in patients with renal disease. Thank you. So the World Sleep Day falls on March 14 with the theme Make Sleep Health a Priority. Thank you, one and all. Thank you.
Thank you, Dr. Benjamin, for your insightful talk on this topic and shedding light on an often overlooked aspect of CKD management. We have a few questions from the audience. The first question being, is actigraphy a part of the smartwatches that we have, or as an app, or does it require a separate device?
Yeah, so actigraphy is entirely a different device. Whatever we have in the smartwatch or the Apple watches will not accurately or capture your sleep activities or your movements. But it can be, there are no good studies which had been done with the watches. But actigraphy has been recommended by the American Sleep Society for capturing your daytime activities and also the nighttime sleep activities. So so we cannot compare the Apple watches with the actigraphy.
Thank you, sir. One last question. In patients with CKD and sleep disorder, in the absence of OSA, is there any evidence for objective benefit of in using sleep medications like melatonin, and what would be the safety and efficacy of these medications?
Yeah, so I've been looking through it. Melatonin, it is safe in CKD patients, and it can be safely given. And using melatonin means even in the OSA patients it can be used, not just absence of OSA, but it will be good to document what the patient is suffering from, other sleep disorders, in the sense whether patient is having insomnia or whether patient is having circadian sleep disorders. Just like that, starting melatonin alone will not do any good. Even, as I said, there are some potential benefits giving melatonin in CKD patients, but those are in patients with sleep disorders. So I would advise getting evaluated by a sleep physician to if the patient has any sleep-related complaints, and then it can be combinedly decided whether melatonin can be given or not given. Thank you so much. Thanks for the opportunity.
Thank you very much, sir, for keeping us wide awake while presenting on a topic on sleep. We request you to receive a small memento from our department.